So yeah, welcome to the Global Emergency Care Grand Round of January 2025. My name's Chris Boyle. I'm a emergency medicine registrar working in Bristol, and I'll be hosting the session today. For those who don't know about the Grand Round, it's Dharura as a organisation are trying to support ethical, sustainable, and equal and reciprocal global emergency care and community health partnerships, and allowing health systems and their teams to gain mutual development through sharing knowledge, skills, and innovations. That statement runs through this process of providing a platform to share both case reviews, research, audit, QI projects between both UK, Kenya, and colleagues elsewhere in the world. Today we have some colleagues from Kenyatta Hospital in Kenya who will be sharing some of their experiences around disaster preparedness. But just if anyone on the call is any interest in case reviews, research, audits, or QIs that they want to share with us as a platform, please share directly via our email address or contact us, sorry, via our email address or via WhatsApp and let us know. We're welcome to hear from anyone who wants to share any of their practice. So before we start, I just want to go through some house rules if possible. We're very used to using online platforms nowadays, but if you can and are able to put on your cameras, that'd be great just for us as hosts and as those speaking as well for great interaction. If you don't mind keeping your mics off unless you want to ask a question. There is a chat function on this, as we all know, so please just post any questions or comments on that and just try and stimulate some interesting conversation throughout the talk that we can pick up at the end. We've got three speakers today, and they'll take up the full sort of hour of talk. So it'll be about half an hour, 45 minutes of talks with sort of 15 minutes of questions at the end. If you haven't done already, in the chat, can you just put in your name, your location, your role, and your email just to help with registration and certificates going forwards. As I mentioned, we'll be recording these sessions and then we post them on our YouTube channel at a later date. If you haven't looked and found our YouTube channel already, you can after today's session, and there's grand rounds from last year as well on that. And so without further ado, I'll stop talking and hand over to the team in Kenyatta Hospital. Just to give it a little introduction, hope Dr. Kimathi is ready to go. Dr. Sudi, Dr. Kimathi, and Dr. Mbuvi, who I've met when I was in Kenya, working in Kenyatta Hospital, and they're passionate about sharing some of their work around disaster preparedness, which I think has been ever too relevant and pertinent in the last number of months and years in Kenya. It's a really interesting talk to be sharing with our colleagues both in Kenya and UK, and I hope we can learn a lot of lessons from the processes they put forwards today. So once again, if you've got any questions, add them to the chat, and if you want to speak up at the end, please feel free to unmic and ask questions at the end. Brilliant. I will hand you over to the team from Kenyatta Hospital if you're ready to go. I'm happy to share the slides from my end. If you're having difficulty sharing, just let me know.
Hello, good evening, everybody. I want to introduce the team. I'm Dr. Kimathi from Kenyatta National Hospital, Accident and Emergency. We'll be doing this presentation together with my colleagues, Dr. Sudi and Dr. Mbuvi. There's some slight modification that has been done on the introduction part of it. Dr. Sudi will take us through the introduction to KNH and its mandate in terms of disaster preparedness. I'll take you through the incidents, and then Dr. Mbuvi will take you through the disaster preparedness. So I'll allow Dr. Sudi to go ahead.
Can you see the slides there, Dr. Kimathi?
Yeah, we can see the slide. You can put it in presentation form.
Yeah, this is control from my end, so I'll just see if I can open that up and just tell me when you want to change the slide. Are you happy that's changed slide?
Yes,
Yeah. Okay.
that's good. Okay. Let me allow him to present.
No problem at all.
Good morning, everyone.
Hi, Dr. Sudi. Thanks for taking the time to speak to us.
Okay, today we are going to have an overview of Kenyatta National Hospital and how we are how normally we prepare for disaster. So my team, Dr. Kimathi, Dr. Mbuvi, and I will be presenting on Kenyatta National Hospital. Thank you so much. Welcome. So our presentation overview today will talk about overview of Kenyatta, visions and missions, key milestones, infrastructure, staff and expertise, patient demographics, roles in national healthcare research and training, and collaboration and partnership. So I'll take the first part about overview of Kenyatta National Hospital. Kimathi? Kimathi, are you there? So Kenyatta Hospital is the largest and oldest referral teaching and referral hospital in Kenya and in Central and East Africa. It was established in 1901 as a small dispensary and has since grown into a full-fledged national hospital. Initially, it was called Native Civil Hospital in 1901, and later it changed the names to King George VI Hospital after the death of the monarch. Later in 1967, it was changed to Kenyatta National, the current name Kenyatta National, to honor the first president of the Republic, the role he played during independence. What is the role of Kenyatta National Hospital and its function? The first role is it works as a referral facility in the nation. So it serves as the referral national hospital, offering specialized medical care to all the patients in East and Central Africa. It also serves as a teaching hospital, which started in 1978 after it affiliated itself with the University of Nairobi. Currently, it has a lot of institutions which are affiliated to Kenyatta. And then it also has it plays also as a specialized, it also plays specialized services like
I think we might have lost you there, Dr. Sudi. Are you still there?
I can't hear him talk.
Can you hear me?
That's better. Yeah, we can hear you now.
So saying roles and functions of international hospital, it also plays as specialized services, offers wide range of specialized medical services, including surgery, orthopedic, cardiology, oncology, pediatrics, and emergency care. The capacity of the facility currently in 2022 had a capacity of 2,400 beds. Out of these 2,400 beds, 209 of them are for private wing. We have 50 wards, 24 outpatient clinic, 26 theaters, and then we also have 82 ICU beds with 6,000 plus staff members. We attend to annual number of around 950,000 inpatient and 800,000 outpatient annually. We also have specialized departments such as acute and emergency, intensive care unit, burns unit, and cancer treatment center, which serve both local and regional patients. So our main focus will be on accident and emergency because this is where normally we receive our normally whenever we have any disaster, this is the area where we focus mostly. So accident and emergency is one of the busiest and most crucial units of the hospital, providing immediate medical care to patients involved in accident, trauma, and medical emergencies. So given its status as a national referral facility, the department handles a wide range of emergency cases, including life-threatening and disasters. The department normally is divided into two units. We have the pediatric emergency unit. This unit normally deals with all non-trauma patients and non-trauma pediatric emergencies from ages 0 to around 12 years. And then normally we do have adult emergency, the one now we call accident and emergency. This one deals with adult trauma and then adult trauma and non-trauma emergencies. So the scope of services for accident and emergency, we do have trauma care. We provide patients with, we provide trauma patients from accident, violence, and injuries, including fracture, burns, head injuries, and spinal cord injuries with specialized care. And then we do have medical emergencies for this unit, whereby we provide urgent attention to patients that have any medical emergencies, which are non-trauma cases. We do also have a theater, emergency theater, which we deal with the patients that need urgent surgeries. In accident and emergency, we do have also resuscitation areas and triage areas. In the triage area, we triage patients and prioritize them based on the severity of their conditions. And then we do have the critical rooms now. Those are our resuscitation rooms. Each and every room has a bed capacity of around 6. So in total, we do have a 12 bed capacity for critical rooms. And in these rooms, it's like full-fledged ICU. We do take care of all those critical patients. We do intubate and do any necessary activity that needs to be done and save the patient. And then the accident emergency is connected to diagnostic services like laboratory and the CT scan and the MRIs. In case we need these emergency services, normally we take our patients there. So the scope of services and the cases normally we handle in accident emergencies, we do have injuries cases like head injury, road traffic accidents, assaults, burns. And for non-communicable diseases, we do have cardiovascular diseases, soft tissue and limb pain, lower back pain, cancers. For communicable, we do have cases like maternal, perinatal, and nutritional conditions, and many, many other cases that we do handle in the department. So I'll ask my friend, Dr. Mbuvi, to take us through how we prepare ourselves for any emergencies and disaster. Thank you.
Sudi, thank you for the presentation. We'll go through the incidences KNH handles soon as Mbuvi prepares to put up the slides. So after the incidents KNH normally handles, we'll have Mbuvi coming in for the disaster preparedness. Alternatively, I can allow him to go ahead. Mbuvi, are you there?
Yes, Doc, I'm here.
Sorry for the small mix-up. Please go ahead with the disaster preparedness, and then I'll come in with the incidences KNH normally handles.
Okay.
Handle. Yeah.
Okay, that's fine. Let me just share. That portion of the slides.
I'll stop sharing for you, Dr. Mbuvi.
Okay, cool. Thanks.
And that should be you.
Yeah. Okay. Yeah, this is me. Just put it on slideshow mode.
Thanks
Okay.
again for joining us and speaking today, Dr. Mbuvi.
Yeah. Okay, so good evening, ladies and gentlemen. My name is Dr. Mbuvi Mutua. I work at the Kenyatta National Hospital together with Dr. Kimathi and Dr. Sudi. I work in the Accident Emergency Department, but I'm also part of what we call the Healthcare Quality Division. So we also look into issues regarding patient safety, patient awareness. And apart from that, I'm also part of the Disaster Management Committee for the hospital. So I'll take you through what in KNH we do in regards to disaster preparedness, and from the brief overview that Dr. Sudi has given about what KNH has to offer, one of the key tenets or things that we usually have to ensure that we are ready for is disasters. For a very long period of time, Nairobi city, even in the times when it was a province, now that it's a county, most of the time you'll find that a good number of disasters usually tend to happen within Nairobi city, and usually tend to get a lot of mass casualties that come into our facility. And so, given that KNH is a level 6 facility, it was imperative to ensure that we have a very robust. Okay, I think there's someone. Okay, but okay. So we had to ensure that we have a very robust disaster preparedness system that can allow us to handle any of those casualties that come in. So as we begin, I'll just give us a brief definition of what a disaster is, which is basically any incident that could end human life or can cause health-related harm and requires immediate response with sufficient manpower and resources. Preparedness, planning, response, and recovery, which those preparedness, planning, response, and recovery also make up what is known as the disaster cycle, and recovery by many agencies, including healthcare institutions. But if we narrow it down to now the aspect of the hospital, when we are dealing with a disaster, we are looking at any incident that may arise that will overwhelm what we call as that will overwhelm the normal responses that we have within the hospital. Basically, anything that will exceed the capacity of us being able to handle that particular incident. So, and when you're looking at disaster preparedness, we're just looking at what actions can we take that can be used as precautionary measures to help us achieve the goal of avoiding disasters and being able to mitigate disasters as well. Yeah. So the other thing that we look at is what is a hazard and what is a risk. So a hazard is a potential source of harm. Basically, anything that can cause harm to a person. This could be anything that will cause damage to health, life, property, or anything that is of interest or value. And then a risk, basically, a risk is the possibility of something bad happening. So as we continue with that, from that, we have to look at the aspects of disaster preparedness. And this is the disaster preparedness cycle, or what we call the phases of disaster management. Now, in the disaster management cycle, you have the four responses that we have here. Let me just see if I can get a pointer that will help with this. Okay, cool. So as you look at this, this is what we call the disaster management cycle. So we have the area of preparedness. We have then a disaster happens. You have the response, you have the recovery, and then you have the mitigation process. So what basically the disaster management cycle usually tends to key into is this aspect of preparedness. And now, if you look at it in the phases of disaster management, preparedness and mitigation usually end up into what we call early warning systems, and you also have your prevention measures. But our key aspect as the accident emergency department within and even the hospital by itself is that we usually try our best to have our preparedness to be on point, so that if and when a disaster occurs, we are able to quickly respond. And once the response has been done, then our recovery process usually tends to be much more smoother. And in recovery here, we're talking about do we need to reconstruct anything, and do we need to have patients who are going on like now rehabilitative care? Then mitigation, now we're looking at, okay, so this particular disaster happened. This was the risk that was involved. These were the hazards that were present. So what can we do to ensure that this does not happen again in the future? This is now what we talk about when we discuss about mitigation planning. And then now in the overall structure, where we're looking at early warning systems, we're looking at key tenets that will actually be able to show us that a disaster is about to happen. And I think as Dr. Kimathi will be going through some of the incidences that we have been able to handle as a hospital, we'll be able to see some of these things. And then looking at things like search and rescue and emergency relief. As a hospital, we are not really involved in search and rescue. So what we usually do is that if a disaster occurs, the casualties are usually brought to us at the hospital. So we're usually more so on the emergency relief aspect, and then the aspect of rehabilitation. Reconstruction mostly usually at the scene where the disaster has occurred, and then preventive measures also now encompass both the hospital and the community at large, as we are trying to ensure that we have a very robust disaster preparedness plan. So now, when you're looking at disaster management, some of the things that you're supposed to do is that you need to prepare yourself when you're looking at aspects of preparedness. So one of the things that you're looking, staff should know the plan, make instructions known, encourage evacuations if they're needed, have an emergency phone list, and be able to notify critical services of emergent needs. Now, when you look at prepare before, what KNH has done is that we have what we call a disaster management. First of all, we have what is called the disaster management committee. Now, this committee is comprised of people in the various subspecialties of the hospital. So we have someone from internal medicine, we have someone from surgery department, we have someone from obstetrics, gynecology, and all those other specialties. But we also include members from the administrative side of the hospital. So we have someone from, let's say, someone from the Department of Finance. We have someone from customer relations. We have someone from marketing and communications. So basically, you're looking at, it's a committee that has various stakeholders who are able to come together and work together in the event of a disaster happening and being able to actualize what we call our disaster management plan. So Kenyatta National Hospital has a disaster management plan, and we also have a disaster management policy. Now, this disaster management plan is what guides us as a hospital on what steps we need to take in the event a disaster occurs. And it covers all aspects of preparedness in terms of a disaster, and also gives clear guidelines and instructions on what needs to be done in every phase of the disaster as we are going through it. So it covers both the aspects of if the disaster occurs outside of the hospital. Let's take an example. If a building collapses and we begin getting casualties coming into the hospital, there's an activation plan of how that disaster plan can be activated. But apart from just covering the external aspect, it also covers aspects of what if the disaster happens within the hospital. Remember that disasters can happen anywhere. So even as for the people who are in this, if you're thinking about looking at how you can prepare your hospital for disasters and things like that, apart from just looking at the aspects of disasters happening outside of your hospital, you also need to have a plan for what will you do if something happens within the hospital. Let's take an example. Let's say if by some stroke of bad luck, something happens like a fire starts rummaging through your hospital. What plans do you have to ensure that you can quickly and safely evacuate your staff, and you're able to mitigate this fire as quickly as possible and to reduce the amount of damage that will be caused to that facility? So our disaster management plan actually covers both aspects of internal disasters and external disasters. And now for a plan to be let's say to be credible, you also require your facility to have what we call a disaster management policy. So KNH also has a disaster management policy that now also guides us on how the utilization of the plan and looks at all other key tenets of what we need to have as we do our preparation to handle a disaster. Now, when you move to the next step, which is now managing during a disaster, so one, you need to be able to utilize your plan. But here's the first thing. If you're going to utilize your plan, the staff who are working in your facility need to know the plan. They need to understand what are the things that we need to do if a disaster occurs. So what we do at KNH is that every year, as part of our performance contract, is that we carry out what we call drills. So we usually have 2 drills every year. The first drill that we do is a fire drill, and a fire drill. So one of our mandates is to actually do a fire drill every single year. And number 2, we have to do a disaster management drill, which can be anything from mass casualty incident. So here we simulate a mass casualty incident. And by simulation, I mean we actually do the proper simulation. We get people to act like victims. We go through the whole process of painting them with red paint so that they look like they have been bloody and they have been wounded. And we just have the whole scene happen. We have ambulances coming in and bringing the patients to our accident and emergency department, and then now seeing how does the accident and emergency department respond to this particular quote-unquote disaster. So that is some of the drills that we do. So far, the drills that we have done have been fire drills, mass casualty incident drills, and one of the newer ones that we did was a CBRN drill. By CBRN, I mean basically looking at chemical, radiological, and nuclear events. So we had one simulation where we said that there's a tanker which was carrying a whole amount of chlorine, and it got into an accident, it overturned, and there was chlorine gas that was emitted. And then now, how do we manage these particular patients who come in such a situation? And we were able to do that drill, and actually showed us a few places where we need to patch up in terms of our response. And those are some of the things. So as you're looking to utilize your plan, you also need to be thinking about, how do I test how ready we are as a facility? Then organizing your staff and other resources to be available. So one of the things that you'll understand about disasters is that, even in its broad definition, is that it is an event that will overwhelm your usual resources on the ground. So if you have, let's say, if your accident and emergency department usually has about, let's say, 4 doctors and a team of about 10 nurses, a disaster will be an incident where so many casualties are coming in that these 4 doctors and the 10 nurses and any other staff are actually overwhelmed. They're not able to give the services that they are meant to do. So as a facility, you need to sit down and figure out, what is our threshold as a facility. If I'll give you an example of KNH. So for KNH, what we call our threshold is, we know that during the day, if an event happens somewhere, if I take an example again of, let's say, a building has collapsed, we know as KNH that if it's during the day and we get about 60 casualties coming in from that accident scene, we will be able to comfortably manage those patients without having to activate our disaster plan. But the moment these casualties pass that threshold of 60, when you go now to 61, 62, then now that means we have to now activate our disaster plan. And by activating our disaster plan, it now gives us access to more resources. And these resources include both financial resources, includes human resource, and includes includes human resource, financial resources, and also like your equipment, and such things. So we have something called a mass store. So in this mass store, which is it's concealed in the accident emergency department, it is a store where we actually just put up equipment and the basic things that we know that we are going to use in the event of a disaster. They are kept in that store. We have regular stock taking, and anytime there's a disaster that occurs and the store needs to be opened, it is opened. The things that are there are utilized, and whatever is utilized, we ensure that once the disaster is done, we replenish our stores so that we are always prepared for the next one. So those are some of the things that you're talking about when you're looking at how do you prepare yourself and how do you manage during an actual disaster event. So the other thing that we need to understand is the reason we have people like now our marketing and communications department being part of the disaster management team is that we have seen that for many times, there's usually a lot of, when a disaster happens and patients are brought to a facility, there's always the aspect of many people now wanting to come to the hospital to just have a look and see what is happening. Some people may be coming maybe to donate blood. Other people may just be coming out of curiosity. And it's good for you to have a marketing and communications team that can actually be able to put aside people who are not patients and be able to give information on a need basis, and also ensuring that the information they're giving does not breach doctor-patient confidentiality. And also, we do not give out information about patients without thinking about if the next of kin of this patient has actually been informed. So it's very key for you to have a marketing and communications team as well as your security team, because the security team is the one which is going to be responsible for cordoning off the area, ensuring that only the key essential personnel who are needed inside that area will be, or the only people will be able to access. So here we're looking at utilizing emergency services, availability of medical doctors, and shared resources. Now, if I talk about shared resources, one of the collaborations we have as a hospital is that we have collaboration with emergency medical services, and these ones include organizations like the St. John Ambulance, the Kenya Red Cross, because in many incidences of disasters, these two, and even the Medicine Sans Frontiers, these teams are the ones who actually bring the patients to our facility. So we usually try as much as possible, even when we are doing our internal hospital drills, that we involve them so that they can understand how KNH operates when we have a disaster. So that even when they're bringing in their casualties, we're able to work seamlessly with them and to ensure that we're able to save the maximum number of patients that we can, given the resources that we have. Another aspect of collaboration that we have is we have collaboration with other facilities that are near Kenyatta National Hospital, like the Nairobi Hospital, which is a private facility. We usually make sure that we have communication with the fire department, the Nairobi County, as well as any other organization that we feel that in the event of a disaster, we may actually need them to help us be able to manage this particular incident that has occurred. So what are the steps that you can take when you're planning to to have a disaster management team, a disaster management plan and policy? One of the things you need to do is what we call hazard vulnerability assessment, or what you call a HVA. So a hazard vulnerability assessment basically is an assessment where you walk around your facility, you try to identify all the possible hazards, identify all the possible risks, and then once you have identified them, you classify them in terms of importance, like which ones are more urgent, which ones do we need to deal with right now, and which ones do we still have time to sort. And once you have done that, you create now a hazard vulnerability assessment. There's a hazard vulnerability assessment tool, and this tool is actually easily available on the internet. You can just Google HVA tools, and it will be able to give you various tools that you can utilize to actually do an audit, a hazard vulnerability assessment audit. Then the other thing, create a unit or a hospital disaster plan. Once you have a hazard vulnerability assessment, it now allows you to be able to create your disaster plan. Once you've created your disaster plan, actually before you execute your plan, you need to train your members on the plan so that they can understand what this plan is about. They can understand what it means to have the plan activated. And then after that, in the event that something occurs, you can execute on the plan. Then the other thing is build a disaster supply kit. Like I said, in KNH, we have what we call the MASTO that is domiciled within the accident and emergency department that is usually fully kitted and usually just waiting in case there's a disaster, we're able to open it and be able to utilize the equipment that is there without having to look for additional resources from other places if we don't really need that much. Then note those with special needs. Then have skills, CPR, BLS, ACLS, understand post-event risks and eliminate hazards. So when you're looking at note those with special needs, those we're looking at your casualties that are coming in. You might have casualties who are disabled and they may need additional support. You may have a casualty who comes in who is deaf, or a patient who is dumb who cannot speak, or a patient who is blind. So these are some of the other key tenets that you need to have. You need to be thinking about with your team about how do we help these people who come in with special needs. And then one of the other things is you need to have a call-out system such that if a disaster occurs today and the disaster plan is activated, there has to be a way in which you are able to call even the other doctors, nurses, clinical officers, everyone else in the hospital who might be either on leave or they may be off duty or they may be maybe in a training or something. There has to be a mechanism where you can actually recall them to come back to work to assist in the event of a disaster. And this is where also having the human resource personnel as part of your disaster management committee comes in, because you realize that in the event of a disaster, you may have to call a doctor who is currently on his leave or he's off duty because he worked yesterday. You may need to call a nurse who's been off duty or she had done a night call and now she's at home resting. You may need to call in additional personnel. And the human resource aspect of it comes in where the HR now will be able to come up with a plan of saying, yes, if we do recall people to come in to help us during a disaster, how well do we compensate them after the disaster has gone? It may be that we may give them an additional day or two to rest, such things, depending on what level of involvement they have been in. So having at least a member of each of the committees, of each of the areas of your hospital as part of the disaster management committee actually is very, very valuable, because it actually helps to be able to cover all corners as you're trying to ensure that you can respond in the best of your abilities as a facility. So disaster preparedness usually, mostly we can look at things like public health emergencies and natural disasters, and how do you become to engage in emergency preparedness and response activities. You need to have a team that is competent and educated. You need to have relevant skills for the responders. let's say if you're I've seen there are several emergency medical technicians in this meeting. So if you're an EMT person and you're called into a place where it's probably a disaster has happened, you're expecting mass casualties. How well trained are you to be able to do a proper SWOT triage at that particular place, so that you know that the patient who will benefit the most is the first one to be evacuated to be taken to a hospital. So those are the kind of skills that you require and the competencies. And then nurses should be prepared to offer maximum patient safety. We need to be able to decrease occupational hazards, prevent things like infections, and things that can happen within the healthcare facility. Remember, if a disaster happens, it does not mean that as the disaster is ongoing, that other diseases have taken a break. It means that even as this disaster is ongoing, you still need to think about what about our other patients who are still coming to get care from our facility? What about our other patients who might be having, let's say, tuberculosis, which can be a challenge in the ED? So how do we manage these other patients as we are sorting out our disaster? Those are some of the things that you need to look at when you're looking at disaster preparedness. And then healthcare workers' role in disaster preparedness, like I said, self and environment organizations. So you need to know how to have resuscitation teams and then maximize on the golden hour. The golden hour, for many of us who are in the emergency care space, we understand about the golden hour and how it literally saves a lot of lives. Then ensure a working HICS. So a HICS is what we call a hospital incident command structure. So as you're making your disaster plan, a hospital incident command structure is one of the things that you need to have. You need to know, in the event of a disaster, who's going to be our incident commander and who's going to be our medical commander, who's going to be our security commander, who's going to be the person in charge of finances. And all this, it's a whole training that has to be done, and most usually done for the disaster management committee. And then you get other people within the hospital to also be trained on the hospital incident command structure. One thing I usually like telling people about disasters and disaster preparedness is, in disaster preparedness, or even when you're actively involved in a disaster and you have to actually do the job, in a disaster setting, the mindset there is really a mindset of a dictatorship. It is not a bureaucracy. It is not a point where we come to discuss about which patient are we moving or which patient we are not moving, or who deserves to go where first. It is usually a very dictatorial state. And that's where the hospital incident command structure comes in. And there's a reason why it's called a command structure. So it's something that where instructions are given, and these instructions have to be followed, because if the person giving the instructions is someone who is well-trained, has the requisite knowledge, and is able to pick out the key tenets that other people may not be able to pick, then you will end up realizing that you have actually saved more patients than you would have. That's why it's very good for people to actually undergo the hospital incident command structure training. It's a very intense training, but actually something that's very good for you to actually do. Then looking at your advanced clinical care relevant skills, what medications might you be using? What is your primary survey and triage and color coding of victims? And this one, for primary survey and triage and color coding of victim, this one actually applies more to guys who will be in the field, the EMTs. So EMTs, you need to undergo training in terms of disaster preparedness to learn how to do a proper quick primary survey and triage and coding, color coding of your patients, so that you are able to evacuate the patient who will benefit the most from the resources that are currently available. And remember, in the event of a disaster, your resources are actually scarce. So you need to be sure how you're going to utilize these resources. And then the other thing, you need to also monitor the ongoing physical and mental health needs of the people who are responding to the disaster and the people who have been involved in the disaster, basically the victims and the people who are responding to help. Their physical and mental health needs also need to be met. So methodologies, like we said, do a hazard vulnerability assessment. Preparedness, you do your education, you train, you do your drills, you develop your plans and your policies. Then stakeholder engagement. If you're a hospital that is, you have neighboring hospitals that are private facilities, engage them. Talk to them about what will happen in the event of a disaster and you get overwhelmed. Are we able to take some of our patients to your facility, and you guys are also able to manage these patients? So those are the things that you need to be thinking about. And then the aspect of response, if we go through the aspect of response, I'll just touch on this briefly. So the first thing that happens is that there's a notification. So what happens in KNH is that, let's say if a building collapses, we usually hope and pray that someone is actually going to call. And most of the time they actually do call. They call and inform us a building has collapsed. We are anticipating that there will be let's say 100 casualties, let's say it was an apartment building, 100 casualties or more. And once they tell us that, let's say I'm the one who's in the accident emergency department and I'm the team leader doctor, the team leader doctor usually immediately assumes the incident commander position. Immediately a disaster is declared. So the thing that I'll have to do is that I will start thinking about, I need to activate the disaster plan. I need to ensure that now we start following the plan. If this plan, does it allow us to have an increase in our surge capacity? Am I able to call doctors from home to come and assist? Am I able to call nurses from home to come and assist? And then now, how are we going to receive the injured patients? Do I need to evacuate my emergency department at the moment and take the patients who do not need to be there to another place so that now I can leave the accident emergency department to be purely used for the management of these patients? And then how do we provide the care that is needed? And then we look at recovery, where we are trying to return to normalcy. And by returning to normalcy, we're trying to look at, okay, how many patients came in? How many patients did we manage to save? What were their conditions? Where have they been? What is their final dispensation? Have they been taken to theater? Have they been admitted to the disaster ward? And things like that. And then now going back to your mass store and trying to replenish all the things that you've utilized so that in the next event, you're not caught flat-footed. And just to summarize, it's a basic thing about asking yourself, are we ready? And by ready, we mean we're looking at treatment. Do I have enough? Do I have sufficient water? Do I have sufficient food? Do I have sufficient medical supplies? And that is in the event of a hospital. If you're the person who's responding in the field, you need to be asking yourself, do I have medical supplies? Do I have flashlights? Do I have a whistle? Do I have a map to the area where I'm going? Do I have a shovel if I need to start, like digging someone who's been like trapped in a place? Do I have those equipment? And then emergency services and other rescue agencies. What emergency services are available to me, either at the facility or at the scene of the disaster that has occurred? Then access. What are the access to vital contacts, both local and international, depending on where you are? Then diet and liquids. Remember, as a responder, you also need to ensure that you're able to feed and you're able to take water, because you do not want to add to the casualties. You don't want to be there, you're busy saving people, but you're not taking care of yourself, and then you also become a victim in the same circumstance. And then why? You are the responder and plan to get help from other sources. The thing about collaborations, you need to ensure that you have collaborations that can actually help you when you're looking at how do I respond to these disasters when they occur. And that is the end of my presentation. So it is just a brief overview of what we do at KNH in terms of disaster preparedness, disaster response, and all those things. And the key take-homes, ensure you do your hazard vulnerability assessment. After that, develop your disaster plan, and then train your people on the disaster plan. And then number 4, ensure that you get collaborations. If you need to sign memorandum of understanding with other people, do that. Yes. And I think I'll now take it back to Dr. Kimathi to take us through some of the incidences that we have been able to respond to as KNH.
Okay, kindly stick there so that you can continue with the slides. I'll be reading, or I'll be discussing with the audience.
Okay.
So for the incidences at KNH, or the incidences that KNH normally handles or have handled so far, I'll take you through the overview of major incidences. I'll do a case study of the fire outbreak. And then we'll look at pandemic or epidemics that KNH and the magnitude in which KNH has handled. We'll look also at road traffic accidents, an example of post-election violence as well, building collapse, and last but not the least, the most recent Gen Z demonstration. Mbuvi, please.
Dr.
The incidences.
Just to interject, I'm just going to say we're running up to 5 o'clock. But I'm more than happy, as you know, to carry on until say 5:30. I know some people may need to get away to other commitments, but the floor is yours. You have as much time as you want, but we'll aim for a 5:30 finish. So that gives you another half an hour to go through this part of the talk. We did start a bit late. Apologies for that, just so everyone's aware of the timings. That's helpful.
Okay, thank you very much. I'll take you through very fast. So now, an overview of the major incidences. So from outbreaks of fire to road traffic accidents to pandemics, KNH has managed to attend to over 20 major national disasters, notably the 1998 Nairobi bomb blast, in which KNH was pivotal in responding to the terrorist attack. We had 2007, 2008 post-election violence, in which KNH handled over 1,000 cases of injuries, including the gunshot wounds and physical trauma. We had 2009 Sachangwan oil tanker fire, in which KNH managed to treat over 120 victims of severe burns and trauma after the tanker explosion in the Rift Valley. 2011, we had a Sinai slum fire in Nairobi. In 2012, we had Garissa terrorist attack, in which we managed the evacuations which were being done to KNH. Then 2015, we had the cholera outbreak. And most recent, the COVID pandemic, in which KNH was the central referral hospital for critical COVID-19 patients, providing ICU care and managing vaccine rollouts. So a case study, we have Embakasi fire outbreak. That the Embakasi fire outbreak, particularly notable in 2018 and 2021, highlighted the vulnerabilities of densely populated urban settlement to disaster. KNH played a central role in treating burns victims and those with smoke inhalation injuries, which we oversaw 30 victims being admitted at KNH burns unit. Next, the Sinai fire outbreak in 2011. KNH response to this is that we're able to attend to over 100 patients with burns injury, including children and adults. The hospital burns unit was overwhelmed and required rapid scaling up of the resources. The specialized care, so the KNH offered both specialized care, psychological support, and collaboration. In collaboration in this incident, we had the Red Cross, a Ministry of Health, and other organizations that came on board to support the patient and staff as well. In the most recent 2020-2022 COVID-19 pandemic, we were the central public referral hospital in which we received a patient who we managed in ICU centers. In the ICU center, we collaborated with the Ministry of Health to provide the services. In terms of epidemics, we have both cholera outbreaks of 2015 and 2022. In both of the cases, KNH treated hundreds of patients presenting with severe dehydration and diarrhea. This notably because of the major slums around Nairobi. Going to the road traffic accident, the Sachangwan oil tanker explosion in 2009, the fuel tanker had overturned in Sachangwan, Rift Valley, whereby the residents were siphoning fuel from the tanker and they were caught in the explosion. So around 120 fatalities and severe burns injuries for dozens of patients were experienced. So Kenyatta treated over 40 severe burns patients whom they transferred from the disaster or evacuated from the disaster site. We also have the Salga black spot collision, whereby we had a multiple vehicle pileup at the notorious Salga stretch involving trucks, bus, and private cars, causing over 30 injuries and 12 fatalities. So KNH managed to get 20 critical cases, primarily involving orthopedic injuries and crash syndrome. Going down to mass casualty incident, in the post-election violence, we've seen that in post the election in 2007 and 2008, there were violence that was witnessed in Nairobi and urban centers, in which over 600 people were displaced. So KNH managed to or received over 1,000 patients who flocked within a span of a week, thereby overwhelming the resources at accident and emergency. So the most cases that were involved were blunt trauma, penetrating injuries, that is stab and gunshot wounds. We had burns patients and finally the psychological and trauma patients. Going on in mass casualty incident, the building collapse. That is Huruma Estate case of 2016. So at the height of Kenya's rainy season, that is in April 2016, a 6-story residential building in Huruma Estate collapsed after heavy rains, leading to dozens trapped under the rubble. The tragedy highlighted the dangers of poor construction standards in informal urban settlement. The collapse resulted in 52 fatalities and left over 135 injured. All these patients were attended to at KNH. Finally, we have the most recent mass casualty incident in which we had Gen Z demonstration. So in June 2024, that's last year, Kenya experienced a significant youth-led demonstration, commonly referred to as Gen Z protest, primarily in response to the proposed Finance Bill 2024, which aimed at increasing taxes. So KNH played a crucial role in managing the influx of casualty from the protest. So in this incident, we received support from Red Cross and AMREF as well. So finally, what are the lessons that KNH learned over the past incidents? One, continuous improvement in preparedness and response mechanism. This involves regular training and capacity building, resource repositioning, collaboration, community education and public awareness. And finally, we've learned the importance of mass casualty protocol in the hospital. So looking back in all these incidents, it's important for the hospital to have a mass casualty protocol and to adhere to the protocols and to know when to activate the mass casualty incident for the response. That's all from me. Thank you very much for listening. Thank you to my colleagues, Dr. Sudi and Dr. Mbuvi. You're welcome for the question.
That's excellent. Thank you so much for sharing your learning around disaster preparedness, Dr. Sudi, Dr. Kimathi, and Dr. Mbuvi. It's really well thought through, all the processes you put forwards. It is complicated and has obviously many facets to it. I've got a few comments and questions I could put forwards, but I just want to open it to the rest of the call to see if there's any questions or comments first. If you want to unmute and ask, if not, if you want to use the chat, feel free. So we've got a few questions in the chat. Some have been answered, and we'll just go through a few of those. If anyone has any questions in the interim, please feel free to share on the chat or unmute as well, or even put your hand up and I'll come to you. Sarah said, may I ask, how do you ensure patient safety while you simulate the mass casualty in hospital? Is the simulation happening in situ or in a simulated setting? And could you summarize how do you practically organize these events? Dr. Sudi has replied to this already in the chat, but if you could give us a bit more detail of that answer, that'd be great as well. So for Dr. Sudi's already mentioned that for our drills, we do it on a normal day and all the other activities will run normal. The purpose of the drill is to see if we can still continue with the normal services when we have a disaster. So I don't know who wants to take that question from the three of you.
I think I can give a comment on that. Okay, so yes, as Dr. Sudi has rightfully said, we usually do the drills on basically a normal day. So what happens is that we usually have, the whole point of performing a drill is to understand where the gaps are. So what we usually do is that we will decide on doing a mass casualty incident drill, we will set the day, and just to ensure that we do not harm the patients who are actually being seen in the facility, there are a few people who are in the know that we're actually doing a drill. So they're able to ensure that there's proper control within the emergency department so that, one, we do not have any panic happening. And number two, we are able to achieve the objectives of what we want to get from the drill. So if I take an example, I'll give an example of when we did the chemical, biological, radiological, and nuclear events drill, because during such an incident, let's say there's a chemical explosion or a biological agent has been released. The one thing that you do not want those patients actually land in your emergency department. Because once they do land inside the emergency department, it means now your emergency department has also become a point of contact, especially if you're looking at chemical weapons, you're looking at biological weapons. So one of the things that we were trying to see how to manage such incidences is to understand, one, when an incident occurs and the call is made to KNH in regards to, let's say, a chemical explosion or something like that, that the person who's calling is able to inform us and what kind of questions do we need to ask them so that we can be able to identify that either this is a chemical exposure or this is a biological event or something like that, so that once we understand that that is happening, we know that once these patients are now en route to KNH, we have a very specific plan of where they're going to go. They will not end up in our emergency department, but we do have an open area, which is usually our helipad, that we use it as a secondary triage or a secondary emergency area for anything that we feel that will be a contaminant for our actual emergency department. So those are some of the things that we usually try to look at and try to think about, work around and see, okay, we have these patients who are coming in, so where do we take them? How are we going to respond to this particular incident if this happens during our normal working days? So that's how we usually end up working in terms of now looking at how we do the drills and to ensure that there's patient safety while we're still conducting the mass casualty drills in the hospital. Yeah.
That's great. Thank you very much. Does anyone else of the speakers just want to add anything to that? If not, we'll move on to the next question. Great. So just I had a question really myself actually regarding how you disseminate the learning from these annual mass casualty simulations or the practices that and the policies that you have in place beyond the simulations on that day, or even the learning that you have after that simulation with the feedback that you've gained from actually carrying it out and finding where the issues are.
So normally we have a verbal feedback to the department. This is done through dissemination of information to the HOD and other supervisors. Then we have publications. In this case, there's one, they started having publication in 2022. We had KNH CBRNE disaster management at KNH, which appeared in the KNH Newsline, edition 7. We also had edition 14 for disaster preparedness training for KNH staff who are at Mama Margaret Hospital. So these are some of the forms in which we disseminate information to the staff at KNH.
That's great. Thank you very much, Dr. Kimathi. Anna, are you still on the call? Did you want to ask your question? She may have. She might not be here. So Anna, a consultant from Truro, has asked, how do you free up personnel to attend these excellent mass casualty training sessions? I know you've answered in the chat there, Dr. Kimathi, about having a rota for mass casualty instances. And I know you may have touched on other answers, but is there anything else you want to add to that? Perfect. So Dennis Miriti, are you on the call? Are you happy to share your question to the speakers?
Sorry, I didn't get you. We are answering Sarah or it's Anna?
It was, sorry, Dr. Kimathi. So it was Anna, one of the consultants from Truro, just asking about how we free up personnel to attend these mass casualty training sessions. And I think in the chat you mentioned having a rota for the mass casualty incidences, but I think specifically she was asking around the training sessions, if there's anything more to add to that answer.
Okay. We have the incident commander at A&E with an office. So there's a rota prepared, and it involves majority of the members in disaster committee, as Dr. Mbuvi alluded. So those people who are normally contacted once there's activation of a disaster. So there's a rota.
Okay, thank you, Dr. Kimathi. Dennis Miriti here. Just wondering that during disasters, I believe that members of staff end up working for extra hours. They end up being in shift longer than the scheduled time. Is there a way that as KNH you have managed to compensate for that, or allowing them longer off? So how do you go about it?
Well, what normally happens is that those participating in disaster response, it's normally on a rollover. So if you've stayed longer than you're supposed to, the immediate supervisor normally is notified so that you're given an off. There is no compensation in terms monetary compensation, but you're normally taken care of in terms of an off day.
That's great. Thank you very much. We've got a couple more questions, then we'll come to a close if that's okay. One question in the chat, is there a specific number of casualties received in the facility so as to term it a disaster? And I think just to add on to that, you mentioned or quoted a number, I think it was 60, which was sort of the threshold for triggering the activation of a mass casualty or a major incident. Just to ask where that number's come from, and is that just due to your own capacity as a hospital or as staffing?
Okay, I can take that one. So yes, for KNH there is a number, and our number is actually 60, and that 60 is during the day. So during the day, like from let's say 8 a.m. to around 8 to 8 p.m. So that's the number that we have. The reason we have that number 60 is from part of the things that some of the audits that were done by the disaster management committee, and looking at certain facets of it. Number one, during the days when we have the highest number of staff within the hospital, meaning that in the event that something happens where it's easy for us to quickly call on additional resources without actually having to activate our disaster plan. And then now at night, the number is reduced to 30. So if we get 30 casualties coming in at night, then now after 30, now we activate our disaster plan. But also the activation of the disaster plan also depends on what kind of casualties are we dealing with. Because if let's say we are dealing with if it's like let's say like the fire incidences that have occurred in the slum populated areas, we cannot hold back and say that we're waiting until they get to 60 burn patients before we activate the disaster plan. Because when you're looking at the overall picture of how to prepare for a disaster, you're also looking at what are my available resources. One thing we know about burn victims is that they require a lot of input. They require a lot of, majority of them may end up with burn injury. So you're thinking about, we may have to intubate many of these patients. We're going to require a lot of oxygen. There's going to be a lot of oxygen consumption. There's going to be need for our plastic surgery team to be on hand immediately. So it actually, that number has been put there for mass casualties. It's one of the things that just helps us to focus and to do our planning. But depending on the kind of disaster that is coming in, the plan can actually be triggered much earlier, especially if you're looking at incidences like fire incidences, because that one we know we are definitely going to need more specialized services or specialized personnel to come in and help us in the emergency department. So at that time, the trigger can actually be much earlier than at the 60 casualty. Yeah.
Excellent. That's really interesting, Dr. Mbuvi, and thank you for sharing your thoughts around that. I've got lots of questions I could ask, but I'm conscious of time, and there's another question in the chat. So I'm just going to ask the question, or if SK is on the call, do you want to unmute and ask the question for us?
Greetings to you all. I hope audible. You're able to hear me. All right, thanks. My question is about the triage system that KNH is currently applying. And also thanks for the presentation. I know we normally have the traditional start triage, and then there's some new systems that are coming up, the 10 seconds TST triage and the MIT. So I just want to find out, in our local setup here in Kenya, which one have you tried out, and which one do you find is actually quite appropriate to include both clinical personnel and non-clinical personnel to assist in triage? Thank you.
Is this in regard to mass casualty or the normal triaging?
This is in regards to mass casualty incidents.
Okay. Mbuvi can take that, please.
Yeah, sure. Thank you so much, SK, for that question. Yes, you've rightfully talked about the newer triage protocols that are coming in, especially the 10-second triage, which are part of the majority of them. We've actually seen them as part of the summit training, what you know as the structured approach to medical mass incidences training. Currently at KNH, the main triage system that we are using in our general areas as the A&D is the South African triage system, which doesn't really doesn't have a lot in terms of mass casualty incident triage. So what usually happens is this: there's the one you're saying, the 10-second triage, and the other modalities of triage that are usually used at the scene of the disaster. Now, one of the things that has really been a challenge for us is getting the right patient being brought to us from the scene of an accident or from the scene of a disaster. The good thing about this is that now the Ministry of Health, through the Ministry of Health, in partnership with the British High Commission, has actually been doing the structured approach to mass medical incidences training, which includes the training of on how to do the new forms of triage, including the 10-second triage. And the aspect of it is that it's now been cascaded down to all the county hospitals, the county referral hospitals, and the county referral teams. We do have, for Dr. Kimathi and I, we are part of the chain of trainers for the structured approach to medical mass incidences, and we are yet to begin these particular trainings within KNH. We're still waiting to get enough of us being TOTs, so that now we can actually be able to start training these particular new triage systems within the hospital that will only be activated as part of our disaster management. So far, we're still using our South African triage system, even when we are handling our medical mass casualty incidents. So when they come to us, the patient will come to us, we will triage that patient afresh, so that now we can give them a classification on whether this is a red-coded patient, orange, or green, based on our parameters within our accident emergency department. But now what happens at the scene of the disaster is something different. And now, because of I will not really say like the lack of training, but the fact that there are many people, many first responders who have not been taken through such trainings. So we usually end up getting just basically what they do is a scoop and deliver. So the first ambulance that gets there, the first patient they get, they put the patient in the ambulance and they bring the patient to us. Now, on our end, we have to do our own triage. As the ambulances keep coming, we do our own triage based on the number of capacities that we have. And then now we're able to re-triage the patients and now be able to handle the patients once they are within our department. Yeah. Thank you for that question. Yeah.
Brilliant. Thank you very much. SK, is there anything else you want to follow on from that response?
Thanks. I've heard that clearly. He mentioned that we are following the South African triage. Just my follow-up will be on the scoop and run. I know how confusing that can be, because you're getting all the patients, and also acknowledging that KNH is a level 6, if I'm not wrong, is a level 6, and it's the National Referral Hospital. So yeah, just a few more comments, Dr. Mbuvi, about the scoop and run, how you receive the patients.
Okay. So basically,
sorry, sorry, Doctor. One more thing. Have you organized? I've heard about the discussion of the helipad, but do you have specific? How do you organize the like the red patients, the green patients, and all that? This in terms of spacing.
Okay. Okay, cool. So for the scoop and run, which is basically what has been happening most of the time, we're still hoping that the trainings will still continue being cascaded down to the EMTs and to the ambulance that actually arrive at the disaster scenes to bring the patients in. So what usually happens is that we get patients who come in, and once they arrive, because a patient can be picked, if I give an example, let's say we're dealing with a building collapse, a patient who has been found who maybe has a fractured tibia fibula and no other major injuries, but he's the first one to be brought into the facility. So this patient will be taken in, and we will just use our normal triage system, quickly do his vital signs, look for any danger signs. If the patient does not have any danger signs, they're quickly assigned a color code, like let's say color green. And within our accident emergency department, the way it's structured, we have a way in which patients who are color-coded red are immediately taken to what we call our critical care rooms. So we have 2 critical care rooms that have a capacity of about 12 beds. And then we have another room that is called the surgical trauma room. And we also have the medical rooms. So once a patient has been triaged red, they usually end up in those critical care rooms. If a patient is triaged orange, depending on whether it's a surgical case, and in most incidences on medical on mass casualties, it's usually trauma cases. So they're usually sent to what we call our surgical room. In the surgical room, they're able to quickly be sorted out depending on what injury they've come in. In terms of priority, let's say we'll probably give priority to that patient who probably has a blunt abdominal trauma, maybe has a fractured femur, but still stable, but need to keep a close eye on them, as opposed to the person who now just has maybe a closed fibular fracture, has some few cuts and bruises. We are able to do that. Now, in regards to the helipad is usually just utilized when it's part of the plan of utilizing it is when we are thinking about what we call CBRNE events. That is your chemical, biological, radiological, or nuclear events. Like I had mentioned, if you have any of this, you will not want this patient to be inside your emergency department because one, if this patient is actually covered by a chemical, it means he becomes a primary source for the people who are within the emergency department. So in that event now, even your emergency department becomes a hot zone. And if that happens, it means things just become disastrous. So we're looking at ways in which, if we do get a patient who has been exposed to a chemical, a biological event, nuclear, any of those things, we want them in an area of the hospital where they will not, one, interact with our other clients who are there. Number two, they will pose the most, it will be a place where it will be the minimum risk to the healthcare workers who are going to be working on these particular patients. And it's a place where we have the ability to design our patient flow in a way that will suit us, in a way that if we're able to stabilize that patient in that helipad, we're able to design a route that can be used as quickly as possible to get them to the room that we need to get them to. That is how that place actually, the helipad area, that is how it works. Yeah, I hope I've answered your questions, SK.
Thanks, Doc. I really appreciate the value of secondary triage, what you are explaining. So, shukrani sana also for the insights that you've shared. Asante.
Okay, thank you as well for the questions. We appreciate it.
Excellent. I hate to say, I think we're going to have to start to wrap up the session now, just because the advent of time we've run over, but for good reason, because that's been an excellent number of talks with some really interesting and topical kind of discussion points to go through. So thank you very much for everyone for engaging, and thank you again to our speakers, Dr. Sudi, Dr. Kimathi, and Dr. Mbuvi, for sharing their learning around such a complex and challenging topic. I imagine that they will be happy to share their thoughts going forwards, and hopefully be able to share their contact details. So if anyone wants to share or ask any more questions, we can sort that out in due course. The video of this session will be uploaded to our YouTube channel in due course, so you'll be able to reflect and look at this session again if you've got anything you want to go back and look at. Just to wrap up then, thank you again, and thank you for your participation. Our next talk, or next grand round, will be on the Wednesday, the 12th of February. And we're hoping to have a pediatric focus in that next grand round. There is a feedback link in our chat. Please click on it. Please provide us with feedback about the sessions and about topics or conversations you want to have going forwards. Once you've completed that with your details, you'll be given a certificate to showcase your attendance. If you are not part of the WhatsApp, or you want someone else to be part of the WhatsApp, please share your or their contact details on the chat, and we'll endeavour to add them to the group chat for future grand rounds. So just to finally say thank you very much again for the speakers for speaking about such an interesting topic. I really enjoyed it, and I've got lots of questions I want to ask, but I think we'll have to park those for another time. Thank you again. Any final thoughts from anyone before we leave? If not, we'll let everyone get away home for a restful evening.
Maybe before we close, I think Dr. Kimathi has put our details up on the chat, our email addresses. And as KNH, we are quite open to having county facilities that need to learn a bit more about how to prepare, how to do disaster preparedness, how to come up with a disaster preparedness plan and policy, because that is something that we have been doing over quite a long time. They can reach out to us. We can link them on how they can now get the official communication through the hospital, and how we can link up with them and be able to just give them a support as we can, so that, because the more people we get to be supported in this disaster preparedness, the better it becomes for us as KNH as well. So we are able to handle cases that are actually, like proper triage has been done and things like that. It'll be actually quite a good thing. And just to say thanks so much for joining us for this discussion. Yeah, thank you.
Brilliant, and that's really, really helpful. And thank you very much for sharing your contact details. Like always, if there's any information people want to share, just message us at our email or via the WhatsApp, and we can share that widely. So that's us for now, and we'll see you in February for the next grand round. Thank you again for joining. See you soon.
Bye.